Good morning, everybody. I know it's nice to get your last hellos and goodbyes in, but we try to keep on time. I'm Tom Fahey, a longtime member of the AES, and I'm honored to moderate a distinguished panel session here about advanced cancers. We really do have a distinguished panel, starting all the way at the end. Dr. Peter Sadow is a pathologist from Mass General. Naris Nilyabal is a well-known endocrine scientist, surgeon scientist from the NIH. Dr. Sarah Hamidi is an endocrine oncologist from MD Anderson. Mark Zaffareo, I think none of you need he doesn't need an introduction to anybody. One of the foremost head and neck surgeons also from MD Anderson, and Dr. Omar El-Kawigi, I think I got that close at least, sorry Omar, who's local, homegrown, University of Kentucky endocrine oncologist. So we're really delighted to have this great panel. We have a case from 4 cases, maybe a 5th if we have time to go through. I'll try to, there'll be questions from the podium, from the presenter. If we need to get some consults from some of the distinguished members of the audience, I'll do that. You know, I still see we have Dr. Shaha there, who's never bashful about giving us his opinion, which is always good. And we'll try to make this a little bit interactive. So let's get started. We're going to start with Omar. Slide should be coming up. Yes.
Good morning, everyone. Thank you for being here. And thank you, Dr. Fay, for the introduction. And I have to say, go Wildcats, since we're in Wildcat territory and I'm local to UK. So without further ado, we're going to get started here with a case. So I'd like to just say a special thanks to Dr. Julie Duber, who's our local pathologist here that helped with the pathology aspect. So this case here is a 42-year-old woman that comes in with a right thyroid nodule. She initially palpated a right-sided neck mass on her thyroid, just incidentally. She is evaluated, and her labs show an undetectable TSH, a normal free T4, and a normal T3. She doesn't have any family history of thyroid cancer, prior radiation exposure, et cetera. So I guess I'll stop here first and say, you know, in terms of next steps, thoughts that the panel might have.
Can we just get our mics on, please? We need these. Yeah, great. Thank you. So, Mark, I'll start with, what do you think? Any thoughts?
So,
we need all the mics on, please.
So looking at the labs, this looks like this patient's significantly hyperthyroid. Looks like she's been that way since 2019. You would want to first get an ultrasound to further characterize this nodule. You'd want to get some labs to check to see if this is Graves or autoimmune. And you'd probably eventually want to get a thyroid uptake scan. Those would be the 3 things that you would want to get. In terms of what order, I don't know that it matters too much, but those would be my thoughts.
Yeah, absolutely agree. And that's kind of how we proceeded as well. And so here are all those things that Dr. Zaffareo discussed. So, you know, high on the differential list and someone coming in with persistently low TSH, a younger person, is Graves' disease. So a high sensitivity test would be to check a TSH receptor antibody, which actually came back negative. Next, we proceeded with an uptake and scan to try to further understand, is this a hot nodule that is affecting this TSH, or is there 2 processes going on? And as you could see here in her uptake and scan representation, so at 4 hours, there was a 7% uptake, and at 24 hours, there was 14% uptake, despite her undetectable TSH. And the pattern of the uptake was primarily in the left upper thyroid. Does this rule out any malignancy at this point? Does this give us any level of reassurance?
Sarah?
So it's saying that the nodule is actually a cold nodule, so it's not the nodule itself that seems to be hyperactive. So I would definitely want to complete with an ultrasound to better characterize this nodule because it may be malignant.
Excellent. And so here we have the ultrasound evaluation of both nodules, the right mid-lobe nodule, which, as we know, did not take up any additional iodine, and the left lower lobe nodule, which did appear to be slightly more, have slightly more uptake on the uptake and scan. Any comments from the panel on these nodules that we're seeing?
I think we can all. I think we would all safely say that the nodule on the right needs a biopsy. The nodule on the left does not. I mean, you could biopsy it if you're considering. I suppose if you had doubts about whether you'd have do a hemi or a total if the nodule on the right proved to be cancer. But I think that would be the way I would go with it.
I would also want to biopsy that lymph node that looks suspicious.
Yes. And so on ultrasound as well, we noticed a right level 3 lymph node that looks suspicious. And so those were sort of the main two targets that we were concerned about. We would agree with Dr. Fay in terms of the left lower lobe nodule not looking awfully suspicious to us, and we decided to forego biopsy of that. And so the patient underwent an FNA of the right nodule as well as of the right level 3 lymph node, which was positive for malignancy with morphology compatible with papillary thyroid carcinoma. And so I will show us here a little bit of the cytology from that sample. Dr. Fay, would you like us to discuss this any further?
Well, I think we can get Peter to comment. Dr. Sato, what do you think? Any?
I mean, I don't really think it's important to comment on this particularly much. I mean, it's an FNA and it's positive for papillary thyroid carcinoma, and that's the comment.
All right. Agreed. So then, ultimately, the patient underwent surgery. She had a total thyroidectomy and a bilateral central neck dissection, right modified radical neck dissection of levels 2 to 5, and 2 to 6, sorry, and parathyroid autotransplantation. And we will proceed with the pathology from surgery.
So the important thing to note here is that you can see extrathyroidal extension. It's microscopic extrathyroidal extension in a case like this, where you can see proliferation into the adjacent skeletal muscle. The discussion would be with the surgeon, what happened clinically? So was it difficult to excise? Did you notice that the thyroid tumor was sticky to the behind to the strap muscle? Because that would determine the stage for us in terms of whether or not it's the T stage is based on gross extrathyroidal extension or microscopic extrathyroidal extension, which wouldn't change the stage, but you can see the tumor kind of trickling out a little bit into the extrathyroidal soft tissue.
Okay.
Just to comment on your previous slide as well, I didn't want to miss this opportunity. I do think it's, before getting to the surgical pathology as well, I do think it's worthy to mention that this patient could have had just a right-sided surgery, lobectomy, central on the right side, and right lateral neck dissection. I think that's an approach which has not been a standard approach, but I think for young patients with excellent prognosis, yes, they may need another surgery down the road, but that's an option for a patient like this. And Memorial Sloan Kettering has some recent data that's a small series of patients, but that would suggest that that's a safe approach, and I think it warrants further consideration and study.
Dr. Shaha, any comments?
Well, Mark, if you were going to leave the other lobe in, would you have FNA'd it just to confirm that it's the other?
Probably. I mean, if you have a 2.5 centimeter nodule over there, I mean, I probably would, force the issue of an FNA on that. It's a TIRAD 3. But, and then if you got something that was indeterminate, other than benign, you may end up doing the total thyroidectomy anyway, but that's a good point.
I think, over years it has been a kind of knee-jerk lateral neck node total thyroidectomy RAI. I think we have swung quite a bit now, and we are paying more attention to de-intensifying the treatment and preserving the best quality of life. And I think what Mark said is very appropriate. We have a pretty large number of patients where we are now doing only lobectomy and neck dissection. I tell you why. Because we work so closely with our endocrinologist, Mike Tuttle, and many times if I have done a total thyroidectomy hoping that he will give radioactive iodine, he will say, no, I don't want to give radioactive iodine. And then I start thinking, why did I do total thyroidectomy if he was not going to give radioactive iodine? So I think there is some change. There is another paper which was published in Archives of Otolaryngology, Archives of JAMA Surgery, which Michael A. has written a nice editorial on that. So there is a lot of interest now in a localized, low-volume neck disease to do a lobectomy and neck dissection and not use radioactive iodine and leave a freedom to do completion if and when necessary. So Mark, thank you for bringing up that issue. Very good. Thanks, Tom.
Barry?
Barry Nabnick, UK. I would just add that I think we're at a very important crossroads that with the advancement of machine learning and technology, and our ability to risk stratify is going to be greatly altered and enhanced in the future. For example, if you do the approach where you're doing lateral surgery, that's extensive surgery, you could maybe with machine learning, whether it's with an FNA or not, with ultrasound, machine learning interpretation in the future, not now. I envision a state where we're going to be able to actually better, more accurately risk stratify patients and really personalize the treatment based on the information that we're able to gather with known and unknown technology at this point in time. So I think it's a really exciting time for our profession.
I think that's a great point. And I also think, in terms of risk stratifying preoperatively, I think as we get better molecular testing and better understanding of that molecular testing, I think that will also help us risk stratify. I think that's a great point.
So the pathology report was read as multifocal papillary thyroid carcinoma, 4.5 centimeters in greatest extent. There was tumor at the ink margin. There was extrathyroidal extension into adipose tissue. And just some things here that our pathologist kind of wanted to highlight. Dr. Sato, I don't know if there's anything you'd like to add on this here.
No. I mean, meaning that the pathologist did a nice job highlighting various features of papillary thyroid carcinoma, but there's no reason to go into it. It's papillary thyroid carcinoma. The issue ends up being the two slides ago was the issue of the surgical margin. One more. Because we've been struggling with this a bit because we don't really believe in surgical margins in terms of thyroids, in the sense that the thyroid's something you can reach into the neck, rip it out, and call it a day. So the idea of a surgical margin tends to be, if the tumor is growing into an adjacent structure, then there's a risk for a surgical margin. If you're doing a lobectomy, there's a risk for a true positive surgical margin. Other than that, seeing tumor at ink, if we just ink the surface, doesn't mean anything except it's a commentary on your surgical technique. So I was just shaming the room. But in any event, you typically know if there's a margin that you're concerned about, meaning because you've taken it out and there's adherence to the adjacent soft tissue. So in this particular case, yes, it's a quote unquote positive surgical margin, but is it? That part is a little bit less clear.
Okay. So we'll proceed. There was 17 of 59 lymph nodes that were removed with metastatic papillary thyroid carcinoma. Those are the various levels. 2.5 centimeter with minimal extranodal extension seen as well. And so, you know, to our endocrinologist on the panel, in terms of thinking a little bit about risk profile based on this pathology. So here's sort of the profile that we saw. It was multifocal, greater than 10 foci. Classic PTC as big as 4.5 centimeter, questionable positive margins, and lymphatic invasion. Any thoughts as to where we might place this per our ATA 2025 risk criteria?
The staging is not right, though. The staging is
Yeah.
T3B.
Because there wasn't
I'm
gross
sorry,
ET,
this
right?
it should be T3B.
It was
you're correct.
microscopic ET only.
Well,
Yeah.
Or even gross would be T3.
If it was gross, it would be 3B.
Right.
Yeah.
Any
It'd be
thoughts
3A.
on, in terms of risk of recurrence?
I think per the new guidelines, just by the extranodal extension, that would already put it at high risk, but there's several factors as well that put it at a high risk of recurrence per the newest guidelines.
Okay. And so thoughts on if we would give radioactive iodine and how much?
So our practice regarding radioactive iodine is a little bit different than what's even in the guidelines, but we don't necessarily just automatically give RAI for all high-risk tumors. We do, especially in this case, I would have gotten a BRAF IHC because this smells like a BRAF mutated tumor. And then I would have also, we get a diagnostic whole body scan. And then with the diagnostic whole body scan, the BRAF as well as the stimulated TG, that's all the information that I use to make a decision regarding RAI rather than just automatically give RAI for all high-risk tumors. And then I see that the patient got 150 millicuries, which would not have been my personal choice of a dose for localized, well, for neck disease, even with the lateral neck metastases. These are doses that I personally keep for metastatic disease. So yeah.
So would a BRAF mutation have influenced your decision for treating with radioactive iodine or not?
It might have. If the BRAF is positive, I have a very low stimulated TG, especially with the surgeons that we have. We're fortunate to have, very experienced surgeons, so I can trust that they did as complete of a surgery as possible. So with a positive BRAF, if the diagnostic scan is not lighting up at all and my stimulated TG is relatively low, then I would be comfortable at least offering the patient the option of no RAI.
Because, just to clarify, but that's because your experience is that BRAF mutant tumors are unlikely to take up radioactive iodine. Great. Okay.
So in this case, the patient did receive radioactive iodine, 155 millicuries. The post-therapy scan showed no regional nodal uptake or distant uptake, and just uptake confined to the thyroid bed. This was her thyroglobulin following this, and it sort of ranged between 0.2 to 0.4 or so over the following 3 years or so. And we slowly started to see that thyroglobulin increase and follow a little bit of what we would call a doubling pattern. At what point would we do any additional imaging or additional workup given that sort of slow but steady rise in thyroglobulin?
Sarah?
So the thyroglobulin was never undetectable, is that it? And
Correct.
Then it went, and the TSH has been stable all along?
Correct.
Okay, well, it went up from 0.2 to 0.4, so not, I mean, I understand that it doubled, but it's still relatively low levels of TG. So if the neck ultrasound is negative, I would still be comfortable with that. If we do continue to see this trend, or if the TG levels become a bit higher than that, then we could get a CT of the neck just to get a more comprehensive imaging of the neck, and then we could also get a CT of the chest to also take a look and make sure there aren't any suspicious lung nodules.
Agreed. And, at this point, we did get an ultrasound, and this is the ultrasound result that we were seeing. There was a new hypoechoic solid nodule that was sub-centimeter measuring 0.9 or so centimeter in largest diameter, located directly posterior to the right common carotid artery. Any thoughts from the panel on what we might do at this time? Thyroglobulin has been kind of stinking around 0.4, 0.5.
I think because it's sub-centimeter, I mean, I think you can watch this. It's probably not going to grow too quickly over time, and that's in general. You could biopsy it and you could take it out, but I think, a lot of times you're trying to minimize the total lifetime number of surgeries for these patients, and so just giving it time, seeing if anything else develops over the years is not a bad strategy. We'd probably observe it for a while.
Would you biopsy regardless if you're going to observe or manage, or do you think the biopsy is only necessary if you're going to be intervening?
Probably not. We probably wouldn't biopsy it if it's sub-centimeter at this point.
I mean, when I see patients like this, I always tell them, you probably have small amount of residual disease. We just need to match our intervention to your disease activity and pace.
Any thoughts from the panel on sort of the proximity of the lesion to sort of vital structures, and if that affects your management one way or the other?
For me, I don't think it would. I mean, I think this is probably lymph node disease, and it's probably going to, if it is against the jug or the carotid, it's probably going to be pushing disease, not invasive disease. I mean, take it into account, but it wouldn't change my management right now at this point.
Yeah, excellent. And I think, and that's just sort of the purpose that we wanted to get at, is that, just because we're seeing it doesn't necessarily mean that intervention is necessary. The thyroglobulin has been stable, the patient is asymptomatic, and sometimes these decisions can be difficult when, in particular anatomical regions that may be, more concerning for where that's located. So I think we'll stop here and we'll move on to our next case.
Sounds great. Thank you so much. Okay, next case will be Dr. Hamidi presenting an interesting case of progression.
Okay, so my case is pretty long, so I'll try to go through it as quickly as possible. But this is a young girl that presented many, many years ago. She was otherwise healthy, had felt a lump in her neck. She saw her local physician, who told her this was a reactive lymphadenopathy. And so they just recommended observation. And then 1 year later, she again had this lump that was still present, had doubled in size, and was now painful. So she went to see her doctor again, was referred to a local head and neck surgeon, and they did an excisional biopsy of a 2-centimeter right neck mass, which came back as metastatic PTC. So she then underwent an ultrasound, which showed a hypoechoic mass within the right lobe of the thyroid gland, which was compatible with PTC. She had multiple other enlarged abnormal lymph nodes, as well as on the right side, as well as non-specific left cervical lymph nodes on the left side, the largest measuring 1.6 centimeters. I don't have any images because, again, this was a relatively old case. But what would be the current approach, question to our surgeon, to a child presenting with a similar cervical mass nowadays?
Naris?
Mostly like adult, but you have to think about other cancers that kids can have. But I would start with the FNA, not just excision, just to know what you're dealing with, because sometimes, you have more information going in and look for other places, and that's where I would start.
And then what extent of surgery would you recommend with this imaging findings?
Mark? Or go ahead, Naris.
So the thyroid and, I forgot, the lateral neck.
She had bilateral lateral neck.
Right, so I've had a couple of kids like this. You go with total thyroid central, bilateral, lateral, and it's a long day, but it'll be rewarding. Sounds
good. So because of the left nodes were just actually looked just non-specific, the right ones were metastatic PTC. So she actually just underwent a total thyroidectomy, with a right modified neck dissection, and this is what the path showed. It was a 1.1 centimeter PTC involving the right lobe. There was focal extension into adjacent soft tissues. There was a microscopic focus of tumor at the soft tissue margin of resection, and then there was a second microscopic focus on the isthmus. 11 out of the 25 lymph nodes that were resected were positive, and there was extracapsular extension in 4 of them. We don't have the size of these lymph nodes. And then there was also 1 centimeter focus of PTC in the soft tissue of the right neck. So with the current guidelines, how would we stratify this patient's disease?
Can we go back to the last slide?
Yes, sorry.
So these pathology findings are amazing. No. So the thing that's important to understand about this is that there's more information that needs to be gained from this. There's a lot of the stuff that's this information that's non-specific. So obviously a 1.1 centimeter papillary thyroid carcinoma is not a particularly large cancer, but I imagine it's probably not a 1.1 centimeter papillary thyroid carcinoma. I imagine there's multifocal disease in this patient's case within the lobe, given the fact that it's present in the lateral neck. We start thinking about a younger child. We want to think about of course you can have BRAF, but in a younger child, the thing you start thinking about are fusions. And most commonly in a case like this where the patient presents with lymphadenopathy, you're going to be thinking about a CCDC6 RET fusion, or the most common fusion seen in diffuse sclerosing papillary thyroid carcinoma. And the reason I mention that is because of the 1.1 centimeter finding, which may be a little bit off in that sense. And so the extension into the adjacent soft tissues is quite common in this disease. Again, typically microscopic extrathyroidal extension, which wouldn't change the stage, and this would be a very low stage T1B if the 1.1 was correct. The other thing to think about too is that there was mention of extracapsular extension. This is not specific enough. So in a situation where we're talking about lymph nodes, because the problem is that, you think the pathologist is a machine. You shove the thyroid and lymph nodes into a box and out pops an answer, where they're people, right? And so they're people making subjective diagnoses based on what they see under the microscope. So the whole idea of extracapsular extension or extranodal extension is up to the whim of the pathologist who's looking at it. So there are guidelines for how to measure extranodal extension, and especially if there's sort of perinodal fibrosis can be confused with extranodal extension. So we do it as a perpendicular measurement to the periphery of the lymph node. And so we actually give an exact measurement about how far extranodal, and this is for most tumors of the head and neck. We've moved thyroid into the same thing because of the de-escalation of therapy in terms of, we won't just say this extranodal extension. We'll say this extranodal extension less than 1 millimeter, 1 millimeter, 2 millimeters. So it would be very, very specific, especially if what we're reporting is going to affect whether or not the patient gets additional, adjuvant therapy. And in a case like this, obviously, if this is from years ago, you're not necessarily going to have the molecular. But the molecular is exceptionally important in case, especially a young person who you're going to want to have the follow-up data for treatment for recurrence.
Okay, thank you, Peter. Let's keep going because there's a lot more to this case.
Right, so I'm just going to go right through it, but the patient after surgery underwent radioactive iodine. She received 100 millicuries, and this is what her post-treatment scan looked like. So she had diffuse uptake in the lungs, compatible with metastatic disease to the lungs. So this case was back in 1995, sorry. And so she received her first dose of RAI at that time, and then was watched with neck ultrasounds without any evidence of disease. And a year later, they repeated RAI just because, that used to be the practice at the time. And so she had received 250 millicuries by 1996. What are your thoughts on repeating radioactive iodine in this case?
This is after her second dose?
No, the fact that they gave a second dose.
Oh.
So I think I would ask the question, one, how many cumulative doses has she received at this point? And what has been her response? Have we seen any change in her thyroglobulin over time? And again, it seems like in terms of when this case may have been, this patient was taken care of, maybe we didn't necessarily have that information up front, but if we knew any molecular profile of this, we could determine how likely is this to be non-radioactive iodine avid. But I would be careful about giving more doses at this point, I think.
Yeah, I totally agree. So she continued to be watched, and so she was getting yearly neck ultrasound and chest x-rays again because of the time where this happened and everything was stable. And then fast forward to 2008, which was her first CT of the chest, and it showed multiple small lung nodules, and the biggest one was in the right lower lobe that I'm showing on that image. So then they decided to do a diagnostic whole body scan, considering, again, repeating RAI, and there was an uptake in the bilateral lungs. And this is what her diagnostic scan looked like. So would you do anything else at this time?
Mark, what would you think?
I think we'd probably just, this was back, we're still back in
2008.
2008. I think we just watch her for now. I mean, you want to know, eventually you want to know what the molecular testing is. You know, 9-year-old, as Peter says, is probably a fusion, but so you probably want to get that answer if you haven't already. But otherwise, probably continued surveillance.
Yeah, I agree, and I just wanted to highlight, it's because the lung nodules are pretty low volume, right? So, and we don't really know how they've been growing or if they've grown at all. So I think it's totally reasonable to continue watching at this time. And this is what happened. So she continued to be watched with neck ultrasounds and CT of the chest. And in 2014, there was no evidence of structural progression of recurrence of disease. And then unfortunately, the patient was lost to follow-up. And she came back to us in 2020. At that time, she was 35. And she presented to the ER with a dry cough, intermittent hemoptysis, and a new painful lesion to the left jaw and the left forehead. And she was unfortunately found to have wildly metastatic disease in the lungs, in the mediastinum. She also had multiple bone metastases and then also a cerebellar metastasis. And these are just some of her images. So I don't know that I have a pointer, but she had a mandibular met, she had mediastinal lymph nodes, a brain mets, and then progression in her lung nodules as well. So what would you recommend at this stage?
So I think the question I would ask is, are any of these lesions at all targetable by biopsy? Because I think ultimately we would want, as we were discussing earlier, to have some molecular testing to guide us here, given the fact that we're seeing that this disease is widespread. And so I think that would be my first question.
Yeah, definitely. So we biopsied the left mandibular mass, and this was consistent with metastatic PTC. And then we ran IHCs for BRAF and PanTrek, and both were negative. They resected the left frontal metastasis. This was, again, consistent with PTC. PD-L1 was 5%, and Ki-67 was 25%. What do we think about these markers, especially the Ki-67?
It's not good.
And then we did NGS, and this revealed an NTRK fusion. So my question for the pathologist on the panel, thoughts about the discrepancy between the PanTrek IHC and then the NGS?
The PanTrek IHC works really, really well in some cases and does not work particularly great in other ones. So we'll sometimes do it as a screen. Now, the description of the morphology in this particular case, if we jumped back, was that it had classic and follicular features. And that's actually, that tumor morphology sort of fits with the fusion, which is why I brought it up, from that point in time. See, we didn't need molecular testing. You just need a good pathologist. But the other thing is that although the IHC is not great, it fits with, oftentimes, it's a screen. So if it's negative, but the BRAF is negative, the high likelihood in a papillary carcinoma is going to be a fusion. So then you'd have to progress despite the PanTrek IHC, which we honestly just use it dismissively. We would then proceed to getting NGS testing because it's kind of the way to go at this point.
Thank you. So what should we do with this patient?
So I think you triage which of the lesions you want to pay most attention to, and I think for me to think about the brain lesions, I need to know what's going on with that. Because other lesions, you probably will have time and see how your systemic therapy works.
Yeah, so she had a left frontal met, which was resected, and then a very tiny cerebellar met. So we're only left with the 5 millimeter cerebellar met at this time in terms of brain. So we started her on systemic therapy, actually, targeting her NTRK fusion. So she was started on larotrectinib, and larotrectinib has good CNS penetrance, and so we were closely watching her small cerebellar met, but hoping that larotrectinib would address it. And she initially had a favorable response with a little bit of shrinkage and then stable disease for over a year. And then unfortunately, she had recurrence or progression of disease in mediastinal lymph nodes, and you can see it here on the PET scans. So her mediastinal lymph nodes initially shrunk and then grew back. She also had progression in the bones as well at that time. What would you do now?
Omar, any thoughts, or Mark?
So I would be asking the question, is this still being driven by this same NTRK fusion, or is there something new in the picture? Again, if any of these are amenable to a biopsy, I think I would be thinking about that.
Yeah, both great points. So we're thinking about acquired resistance to treatment and or transformation into something more aggressive, right? So we biopsied one of the progressive mediastinal lymph nodes. It was still PTC, and then we did NGS on that, and you can see that she had acquired an NU NTRK mutation, which gives resistance to first generation NTRK inhibitors. And I don't know if our pathologist wants to comment at all about this NTRK mutation.
Yeah, so it's not about the specific mutation, although in this particular case, what they'll typically do is switch the small molecule inhibitor in patients to try to get rid of the subclone that's causing progression. So that is exactly as Mark mentioned. Typically, in any of our patients that progress on drugs, we redo the molecular to look for these resistance mutations, and if they're there, they swap out the drug.
So again, I'm going to move over this, but it's just to highlight that there are several mutations that are known to give resistance to the first generation NTRK inhibitors, and so we have to look for those because it means that our drugs won't be working anymore and we need to switch therapy. So what happened afterwards is at that time we had no other options actually to target this new acquired resistant mutation. So we wanted to try and keep her on the larotrectinib and address the oligoprogressive disease as much as we could with localized therapies. So some of her mediastinal lymph nodes were resected surgically. This was consistent with PTC. And then 1 month later, she noticed that one of her teeth was looser. And there was like a hole in her gum that was adjacent to her last mandibular molar. And I don't know if we can see it pretty well in the image, but there was like a hole in her gum. She continued to have also at the same time disease progression in the neck, as well as that lesion that ended up being a met. And other bone mets were also progressing. So this is what her mandible looked like. And what's also important to highlight in that case is that initially her thyroglobulin levels were relatively high. They responded pretty well on the larotrectinib, and then although she was progressing, her thyroglobulin levels remained relatively low. So any thoughts on that?
So, it's kind of paradoxically a little bit more worrisome to me, even though the levels are going down. The fact that there's structural progression is suggesting that maybe this is dedifferentiated disease that's not making thyroglobulin very well.
Yeah, 100%. So what we did at that stage is we resected the left mandibular metastasis that was progressing, that was causing her lots of pain. So it was mainly for palliative reasons and to help with pain management, but also to address the progressive disease. And on pathology, what we saw was anaplastic transformation. And I have a few slides. I don't know if we want to comment on them.
This is disease that's invasive into the mandibular bone, and it actually there are two views. On the left, you can see it's still like a more classic appearance in papillary thyroid carcinoma, and on the other panel, it's more solid in its growth pattern, and I'd need to see it a little bit more higher power. Is there one, or is that it?
Oh, that's it.
Oh, okay, it's
Sorry.
lesion.
And then I'm just gonna fast forward, but basically she continued to progress. She had more bone mets, and we addressed those with radiation, again, because we didn't really have any good systemic therapy options to offer her at that time. She would have also benefited from anti-resorptive therapy for her bone mets, although she declined it. And so we irradiated the growing bone mets, and then she continued to progress, unfortunately, both in the bones, mediastinal lymph nodes, and she also had new brain mets. And at that time, we were fortunate enough that there was a second-generation NTRK inhibitor that had just been approved for lung cancer, and we were able to start her on that. And she's still on that drug, which is called repotrectinib, so that's a second-generation NTRK inhibitor. And then we added pembrolizumab to that as well, and she's still on the combination about a year and a half later. She is doing okay, I would say. She has continued oligoprogressive disease. She's had new brain mets that were resected twice, progression in the mandible that was reoperated on. So it's not the great success story, but I had an updated images, and these are not my updated slides, but she has relatively low volume disease at this day, and she's doing relatively okay. So this is just an example to illustrate how these pediatric patients can evolve over time, and how we can try to treat them and keep them alive for as long as possible. And I think we can move on to the next case.
Thank you, Dr. Hamidi. That's a great case. Thank you. Naris. We're going to shift gears a little bit away from the neck.
Morning. So let's see. All right. So this is the title of my talk, A Rock and a Hard Place. So this is a case of bilateral field paraganglioma and polycythemia. And the story started when she was 16. She presented with severe hypertension, and at that time, outside hospital was diagnosed with multiple recurrent abdominal paragangliomas when she came to us. She was born small. She had some quote-unquote heart conditions, and she had heart surgery of unknown details. Later on, she was a young kid. She had some systemic vasculitis. She was treated on these drugs, steroids, and treatments to thin her blood. And when she became about, school age, she developed polycythemia, and she needed multiple phlebotomy to lose her blood, and her EPO was sky high. To the point that her blood was so thick that she got TIA and had severe hypertension that was relatively uncontrolled. So she fits in with this syndrome, Pachak-Zhuang syndrome. These are two NIH investigators who discovered this disease, and that's why she referred to us. And it's a rare tumor predisposition syndrome caused by the gain-of-function mutation of the HIF2 alpha. And it's not usually germline, it's a post-zygotic mutation called mosaic. So they represent like that, early age, recurrent tumors, paraganglioma, and if you have to choose from ABSITE, it's somatostenomas. That's the common neuroendocrine tumors in duodenum associated with this syndrome. And as I said, it's post-zygotic events, so cannot be germline tested in some cases, and you have to look at other places. And this is activating mutation, so you have a lot of HIF2 alpha because of poor degradation of HIF2 alpha. So before she came to NIH, she had a bone marrow biopsy to confirm this is true polycythemia, not other myeloproliferative disease. And a year before that, she got surgery, so-called a biopsy of her lesion that confirmed that to be paraganglioma. And then she came to NIH, she got a bunch of scans. I'll spare that. F-DOPA was the best scan for this. I know it's not FDA approved, but we do have it, and I'll show you. So she showed multiple masses in adrenal glands, retroperitoneal tumors, and the difficulty is that her right kidney was atrophic, and the function was 28% compared to the left. And let's see, hopefully it's going to play. Oh yeah. So you see there, hopefully it keeps playing. Where's the mouse? Okay. Well, you see big tumors on both sides, arrow caval there, and keep going there, and then you see a tumor right posterior, right there where I paused, behind the left renal vein. And both, I think that's the left adrenal gland. So here's F-DOPA. So right adrenal gland, left adrenal, oh, that's underneath the left renal vein there, and a bunch of nodules. So this is very common for this syndrome. They come in with multiple paragangliomas all the way down. So you know it's a long day. And it's a redo, so I don't get virgin abdomen. So surgery, here it went. So we did a right total because it was big tumor, and we did a left partial, and we excised all those big tumors in aortic caval, periodic mass, and I always leave the best for last, which is the left renal hilum. Well, it was real stuck, so I lift up the gonadal as I divided it, and I tore up a little bit of left renal vein. Got it controlled. So here we are. What are we going to do? Because her right only had about quarter, function of her renal function, and we have a left renal vein injury. Do I take the left kidney and would leave her CKD about 30s, or we repair it, or should I leave it back in there?
So Naris, if you repaired it, would you be leaving tumor?
Yes. I can't fix it unless I cut the kidney out. Well, I can repair it, but I'm just saying I would leave in the tumor.
Thoughts from the audience?
Oh, sucks for me.
Or-
It was pretty stuck, so meaning just cut it out and reimplant.
Auto transplant, yeah.
No, because it was close to the hilum, to the kidney side. So typically you can stable off the left renal vein, there's no issue. As long as you want, keep gonadal, and it can drain through the lumbar, and we do that all the time. But this one is real close, she would not have any exit.
So one other option, Scott Wilhelm, Cleveland, one other option, and it might be challenging, but if you have transplant surgery available, you can consider resecting the left kidney, take the renal vein. You may have to do a saphenous vein harvest at the same time, and then do a left iliac auto transplant of the kidney at the same time. Now you took your long day, Naresh, and you made it a whole lot longer, but you could potentially salvage that left kidney. I don't know if you had ureteral involvement or not. Hopefully you didn't, and I know you said the gonadal was clear, and you took the gonadal to try to get access to this. So you kind of, like you said, you've already sort of burned that bridge, but that's another potential option. It's challenging to ask a transplant surgeon to come in and do that on table while you're there, but that may be your only way of saving this kidney, but I would really try to save it.
Right, so we have a urologist who do this sort of thing all the time, not the transplant, but to deal with the vein. So we look at each other. He said, well, you got to take out a kidney. I said, let me try to fix it, and I fixed it. So we look at each other, so now what? Well, before I went to the case, I already know what her problem is with, genetically, and here's what I want to emphasize, how basic science translation can help you out from the OR problem. So at that point, a little bit of bleeding. Well, so many tumors, got to give me a credit here.
A little bit.
A little bit. But luckily, she started very high, right? So only 4 units. So I don't tell the total liters, I tell how many units I gave her back. But anyway, so we did not do we left the tumor in situ. And the reason I'll show you in the next slide, And there's a reason for it, because she's young, she's going to get dialysis sooner or later, and I don't want to do that. And there might be a way out of this, I think. So the path was nothing surprising. It's a field pregangliomas. They're multiples and not usually metastasis, but they can. So here's my way out. When I thought of that kidney, right, because she's had HIF2 alpha everywhere and EPO was high. So belzutifan was just approved for VHL, which I am also a PI of that protocol. So I'm familiar with the drug. So belzutifan is the inhibitor of HIF2 alpha. It's very specific. And this is the basic science that UT Southwestern scientists have discovered. Once undruggable transcription factor is now druggable with remarkable response in the VHL, to the point where you see complete response or over 90% here, especially if it's a PNET, it's more than 90%. So I thought of that, so that's why I left it in place.
That's just for VHL mutant
Yep, that's
peanuts?
for VHL. What about this? Happened a year or two before that case. There was a case report in the New England Journal of Medicine about belzutifan in this exact syndrome and showed good response. So I thought, okay, I'm going to give that chance. So I saved her kidney, and she started on belzutifan. But she's from Ukraine, and it's intermittently accessible to her, so she didn't really get the drugs all in her system. And here's what happens. So you see, those were not there. Within the year, this thing can come back, and I operate 7 to 8 times in these patients until I couldn't go anymore. So that grew a little bit there. You can see the landmarks of Strucco there, the bunch of carpets of clips. So those are, and she got new lesion there and maybe one in the bottom. So now the lesion has grown a little bit, a couple of new lesions, and then she was lost to follow-up. She came back here. The one on the left is 3 years after the initial surgery compared to 2 years on the right. So the new one has become more obvious, shown there in the middle, big bright spot there. And her tumor became this. So it's bigger, and a little new one there, and that's very common. All right, you got the idea? So now what? So that's where we are now.
So presumably this is on the belzutifan or not?
She's on and off. So she's now in Germany. She said she could get to a trial and will start belzutifan, but it is that part. I'm going to assume that she may not be so reliable to get it, or, so since it's grown over a few years. So what are our options here?
Dr. Anabnet.
A very tough case. Do you know her somatostatin receptor status? And
Yes.
the fact that uptake is encouraging, and clearly a beta, lutetium-177 PRRT, and now the new alpha emitters, the 225 actinium, and I think it's 212 lead. But they have tremendous renal toxicity. We were talking to Dr. Howe about that yesterday, and I asked their experience, and there's tremendous renal toxicity that would probably tilt the balance, but that can be used as sort of a next step in her disease management.
Yeah, so that was one
And it's
thought.
available in Europe, not in the US.
Yep, so we have lutetium 177 on clinical trial at the NIH for advanced field preganglioma as well. So that was one option that we considered. So here's my thought, and so I spoke with a transplant, like Scott said. They would offer her to do a tumor en bloc resection, do back table and perfuse the kidney on table and cut it out and put it back in the pelvis. So that is our current plan for her.
You could do that and then follow that up with PRRT. Because if you can debulk and then and again, the alpha is much more specific, but it's perhaps going to be more toxic than the lutetium-177.
So the way I think of PRRT and this kind of disease is that I would keep it because it's a one-way trip, right? PRRT, you can get it and that's it. You have one time, you max your dose and that's it. So I'll keep that option when I cannot cut anymore. And as long as he can get belzutifan, it won't take the tumor away, but it could control the tumor until something else happens, and we can move on to PRRT. Because she's very young. She's going to need something at some point down the road. And that was that one.
Great case, Naris. Thank you. We have a few minutes, Mark. I think your case seemed shorter, at least the part that I saw. So I think it's a good case, so I think we should just try to get it in.
So the most important thing in this is to stay on time. I read these instructions, and it's bolded and underlined, so we'll do this in 5 minutes. Because we don't want to start the award ceremony late. So that's my disclosure. This is going to be really fast. And I do have some clinical trials that are supported by industry. So this is a 59-year-old lady without significant past medical history other than she's very overweight, has a large neck mass 5 years ago. It's been slowly growing since that time. She didn't have insurance, so she's just now coming in. And she has some slight voice changes and notices a little bit of change in her breathing. On exam, she doesn't have stridor. You do a flexible laryngoscopy. There's some little bit of mild laryngeal edema, mass effect, especially on the right side. And she's got the right vocal cord is a little bit hypomobile compared to the left. So we do an ultrasound. This was actually, this ultrasound and biopsy were done elsewhere before the patient came to see us, but it's PTC, and she's got this thyroglobulin. Our endocrinologist, any thoughts about the PTC with this thyroglobulin?
What was the extent of her disease again?
She has, we'll get there, but she's got a big tumor in her neck.
Okay, well, I mean, I definitely want to at least get a CT of the chest because this is quite a high thyroglobulin, although, I mean, we do see numbers like that with just very extensive neck disease.
Yeah, so it looks like it's probably not too dedifferentiated. I mean, it's producing a lot of thyroglobulin. So the molecular testing, this patient has the BRAF TERT combination as well as a few other rare mutations here. So it's an aggressive BRAF TERT mutated PTC, and so we just go straight to the CT imaging. It's a bad tumor. It almost looks like it could be like an anaplastic tumor, except this is PTC. I think the main points here. I think we won't ask to interpret this, but your right nerve is already a little bit weak. It's going to be at significant risk. Maybe the left nerve is going to be okay because looks like that tracheoesophageal groove is probably okay. You look at the bottom right picture, and there's carotid encasement. I mean, maybe there's a little tiny piece of the carotid which is not encased, but it doesn't look very good. And then down here in the mediastinum, there's a little bit of concern. It's hard to tell there if this is kind of pushing on the trachea or if it's actually in the trachea. Of course, you could, if you wanted to do a broncher to look at that, you could. And the margin with the esophagus is a little bit unclear. So there may be some muscularis involvement. She's not having a lot of swallowing issues, so usually if there's not having a lot of swallowing issues, it's not intraluminal in the esophagus, but definitely maybe potentially involving the muscularis. So this is what it is a PET-avid tumor. There's no distant mets on the PET imaging. And I guess in terms of treatment options, this is a room full of surgeons. Anybody surgery? Just audience poll. Systemic therapy? Yeah, so most think that we should start with systemic therapy. I think that's what we should do. So I guess, one question to the endocrinologist, what should we do? What are our options in terms of targeted therapy?
Yeah, I think this is a dilemma that we always have at our tumor boards, right? Should we do BRAF MEK inhibitors versus lenvatinib or a multi-kinase inhibitor? Per the guidelines, we should be doing lenvatinib upfront for locally advanced disease because that's what's FDA approved is lenvatinib as a first line. I think, though, both options are valid, and it really depends on several things that we think about. So first, we know that BRAF MEK inhibitors will shrink the tumor a bit less than lenvatinib, especially if we're talking about a well-differentiated tumor. Now here, the tumor is pretty FDG avid. It looks very aggressive, so I do have some hope that it will shrink pretty well with BRAF/MEK inhibitors. And then because of the carotid encasement and the risks with anti-angiogenic therapy, I would personally favor BRAF/MEK inhibitors in this case. And then if we don't achieve the response that we want, then we could potentially switch to lenvatinib afterwards.
Yeah, I would absolutely echo that. I think the thing that also kind of helps me decide in these sort of circumstances is the anatomical picture, right? So because of that higher risk of, with anti-angiogenics, sometimes we lean more towards BRAF and MEK inhibition in that case. So I would keep that in mind.
And I forgot to mention also, there was some trickle invasion, right? So we could also have some concern for fistula with lenvatinib, which would be another thing to take into consideration.
Yeah, great points. The patient did get dabrafenib, trametinib, the BRAF/MEK inhibitor combination for 9 months. And then kind of we look at the response here. This is after 9 months of DT. I mean, so I think what kind of response do we expect in with PTC and maybe we can contrast that with ATC for the BRAF/MEK inhibitors for patients that have BRAF mutations?
Yeah, I mean, definitely I would have wanted more shrinkage than that. And as I mentioned, I was hoping that this was a bit more aggressive than just a run-of-the-mill PTC, because those tend to respond better to DT. The more aggressive the tumor, or the closest we get to ATC, the more shrinkage we're going to be seeing. Whereas with just regular PTCs, typically we don't see much shrinkage, and the response rate in the trial was about 30%. So we don't expect these dramatic changes for PTCs like we see with ATC, with dabrafenib, trametinib.
Yeah, great points.
There was a question, Dr. Z.
Oh, question, yes.
Mark Surrey, Parangi, Boston. I was just wondering, would anyone have considered immune therapy as an addition to the BRAF and MEK in this case, or no, never?
Not upfront, because it looked like a well-differentiated tumor in PTC. We only use immunotherapy when we're suspecting ATC, which here I didn't have really clinical suspicion of.
Yeah, it's a great question, great point. So yeah, I think we did get a little bit of response. If you kind of look at this is the before and after. I think the carotid looks a little bit better in terms of maybe you can start to see the a little bit of plane around the carotid there. So you get about a 20-30% response. It helps a little bit. It's still a tough surgery. So and this is what the difference in the PET. There was a general decrease in the size and the SUV. Also, the SUV also went down a bit with the therapy, and there was no distant disease. So what do you think about this last question? What do you think about this thyroglobulin? It goes up to, I mean, it's the TSH difference is noted there, so that's part of it. But I was curious why this thyroglobulin jumped to 43K after DT.
We tend to see that on DT. These drugs redifferentiate the tumors, so we tend to see thyroglobulin going up on these drugs.
Great. You could either continue the targeted therapy or do surgery. We did surgery. It was a big resection. We did actually have to resect some of the muscularis, and we did a tracheal shave. We did get a posterolateral tracheal tear, which was pretty significant, 4 centimeters or so, which we repaired and then put the sternohyoid muscle between the trachea and the esophagus just to give it some extra protection. We did have to sacrifice the right IJ and sympathetic chain and the right nerve. So even though the right nerve did have some mobility, it wasn't completely paralyzed. It was completely encased and sacrificed. And here's our pathology. It was a conventional PTC. I was thinking maybe that there would be some high-grade anaplastic, but there was not. I mean, I guess based on the TG, this is what we would have expected. So any thoughts from our pathologist on this?
Well, based on I actually was agreeing with Saray when she mentioned about immunotherapy, because even though you had a BRAF plus a TERT promoter mutation, which is a setup for evolution to anaplastic, and it was a large tumor and potentially is heterogeneous, and maybe the biopsy was of the the sort of well-differentiated component of the tumor. So I would still be concerned about this being having some sort of anaplastic transformation at some area of it, or at least high-grade transformation. So I probably, in cases like this, we sort of do kind of preemptively order PD-L1 for the option because a lot of our ATCs, when we stain them, actually stain very strongly for PD-L1. So we might have just doing that to make sure we'd have something in the bank in case you wanted to go that route if it, you know, the initial treatment didn't work. The other thing that because a lot of patients now are getting neoadjuvant therapy prior to surgery, we do tend to comment in the pathology about the extent and type of treatment effect that we see in the tumor. So if there's tumor necrosis, if there's extensive fibrosis, obviously we don't have the before to compare it, but we comment on whether or not there's treatment effect in the tumor to sort of think about, you know, adjuvant therapy following surgery.
Can I comment a couple of things just to add on what you just said? Kind of a counter argument that I would use that this did not, I don't think that this was ATC is because of the response to DT. So the fact that it didn't shrink a lot on DT alone makes me think that this is probably not ATC, and that's why I would not have added immunotherapy, just because with ATCs, unless they have a PI3 kinase mutation, which confers primary resistance to DT, we see them melt in front of our eyes within a few days. So the fact that it barely shrunk, it really is DTC behavior. And then just as a comment about the PD-L1, we typically don't use PD-L1 status to make our decision about adding immunotherapy for ATCs. We do stain for it, and I definitely agree, and I kind of look at it, but I will still, if this is an ATC or if the path had shown that there was an ATC component, I would have added immunotherapy regardless.
Yeah, great points. So in this case, there's a question about radiation to the neck, radioactive iodine. We chose not to give radiation to the neck, and patients plan for RA evaluation, and of course always want to get them evaluated for the vocal cord paralysis and get a quick injection in there, and they can get an implant down the road. So thank you very much.
So maybe I have time for just one. So Mark, why not XRT? I mean, that's an interesting, I mean, I think there would be many who would recommend XRT in this case.
Yeah, I think that it's the radiation's going to have. I mean, the patient's got one nerve left. You radiate a patient like that, you know, they're going to have some effect on their swallowing. They could also, you know, have some effect on their voice and their even occasionally breathing. I mean, I've seen single functioning nerves go out during radiation therapy occasionally. It's a good point. I mean, it could be considered. I don't think there's a right or wrong answer. But we were going to give radioactive iodine a try, and
I would also add that in the future, if you would want to give an anti-angiogenic to this patient, I would rather you don't radiate her neck.
Okay, any other comments? I know we're over time, and Carrie's going to come up here with a big hook. But thank you. That was a great panel. Thank you to our panelists, and really, really great session.